The broadcast is now starting. All attendees are in listen-only mode.
Hi everybody, welcome to the Brown Bag Lunch training series from Family Voices of California. This is a training series on health and policy topics affecting children and youth with special health care needs. Presentations are typically geared towards families, professionals, parent-to-parent staff, youth, and everyone else who would be interested. Today's topic is on addressing the multiple issues in collecting race, ethnicity, and language data, and we welcome Vivian Jackson from the National Center for Cultural Competence in Washington, D.C. Let me give you a few notes about the technology if you're new to it. Unless you're absolutely sure that you have a headset with a microphone that allows you to speak through your computer, when it comes time for questions, you'll either need to call in using your telephone or type in your questions. You can find the call-in number from your confirmation email, or while you're connected, you can go to the audio menu, select telephone, use telephone, and it'll give you a dial-in access code and audio pin. If you are using the telephone to connect by audio, just remember that there are local toll charges that apply. And if you have any technical difficulties, you can either call GoToWebinar at 1-800-263-6317, or you can send me, Tara Robinson, a chat or a question. We typically start with everybody on mute because there are a lot of feedback issues when we get a lot of people on the line. So there will be opportunities to ask questions throughout the presentation, but if you'd like to ask a question, you select the little hand icon. It looks like a little hand with an arrow, and that means you're raising your hand so that we can tell that you want to say something. Either that, or you can email us a chat or a question. Not email, send us a chat or a question. And yeah, so I think that's it for now. Oh, and just so that everyone knows, we will be putting this up as a video on our website, and the PowerPoint slides will be made available afterwards. It's always a question we get. Okay, so with that, I'm going to go ahead and turn it over to Vivian. Thank you for joining us, Vivian.
Thank you very much, Sarah, and welcome to all. It is certainly my pleasure to spend some time with you today. We are going to be talking about collecting race, ethnicity, and language data, and in some ways it sounds like something that's rather dry. In other ways, for me in particular, it is really something very exciting because we are talking about finding strategies and ways to begin to put our talk about cultural competence and addressing disparities into action. So let's look a little bit at the state of affairs. We know that there are several forces that are promoting our increased attention to diversity, to multiculturalism, to despair, and things like that. And one is just the sheer numbers that the country as a whole, and California is certainly on the front edge of this trend, that our demographics are saying to us that there are so many things that are different and similar amongst people that we need to pay attention to the particular needs and issues of the segments of our population. We know historically that there has been and continues to be disparities in issues around access and quality of care, particularly of those who are in racial ethnic minorities as compared to those who are in mainstream majority populations. We know that there is a push for quality, and as we look at issues of quality, we need to identify who's getting what, why, where, and what those outcomes are and what is important to them. And finally, we're looking at issues around equity, that there is a stronger and stronger push from a moral frame that services need to be fair, and that regardless of who you are, that there is that entitlement to good quality care and outcomes. So those are some of the things that we're seeing that are kind of pushing us in a way to look at what we're doing in a different way. So it's not always easy to do that. So some of the things that we're facing are some of the entrenched attitudes, biases, stereotypes, and isms that have been part of the history of this country and the history of the world in many ways. But certainly in this country, issues of race have been a very central concern, target, polarizing theme within our country. And along with that comes issues around privilege and issues around power. So as a nation, it has been one of those things that has been very uncomfortable to really engage in dialogue and discussion and solution finding around issues that have anything to do with race and those related themes like immigration, like sexual orientation, like gender identity. All of those things are things that have been difficult for this country to engage in a comfortable way. And so when we are kind of facing the technical task, it surfaces all of these discomfort within our society. So let's really think about what it is that we are talking about, because these are terms that we use, and as with many terms, one person can use it and have a very different understanding in their own head as compared to someone else who's using the same term. So let's first look at the term race. Dear Webster, you'll see two things in the definition of race that comes out of Webster's work. One speaks to a local, geographic, or global human population distinguished as a more or less distinct group by genetically transmitted physical characteristics. What you look like, with the color of your skin, the features of your face, the texture of your hair, your body type, are things that are part of our historical way of thinking about race. Race equals what you look like. But Webster also talks about race as a kind or a class or kind of people unified by shared interests, habits, or characteristics. Well, they have been merged in our heads in some ways, that people who look a certain way have certain shared interests, habits, or characteristics. But we know that that's not necessarily true. But it gives a picture of the type of confusion that we all have when we use a term such as race. One that we note is that race is really socially defined, as the geneticists have kind of studied what it is that really separates one group of people from another. Genetically, we're all pretty much the same. And as we look at within race issues, there is as much diversity within these categories as there is across categories. But there's something that is important for us to think about as we look at this issue. And perhaps looking at the term ethnic or ethnicity can help us with that. Again, looking at the Webster language, ethnic, of or relating to large groups of people classed according to common racial, national, tribal, religious, linguistic, or cultural origin or background. An affiliation or quality. Moving on, how one sees oneself and how one is seen by others as part of a group. Presumed ancestry, shared common destiny. In some ways, these terms are probably terms that more accurately help us get a sense of the values, the beliefs, the worldview of any group of people who might have shared physical characteristics, who might have a shared ancestry, and that these are terms that may have more value when we think of issues of health beliefs, attitudes, understandings of what makes life work for them, disabilities, or whatnot. And then there's this term, REL, the new acronym of the day, Race, Ethnicity, and Language, which comes from the Institutes of Medicine as it has begun to really think about how to deal with this issue of disparities, and we'll talk a little bit more about that later. One other piece that I want to kind of remind us of is that when we think about cultural competence, we're talking about organizations that have defined set values and principles and show that in the attitudes, behaviors, the policies, the structures of the organization as a whole that really promote effective cross-cultural practice. The work originally done by CROSS, and which we have really adopted, we know that these are organizations that value diversity, that actually celebrate things that are different about each other. They're willing to look inside of themselves and identify what's working well, what's not working well. They acknowledge that any group of people who are going to come together with different histories are going to work well together in some domains and not so well together in other domains, and yet they have found a way of looking at the variety of ways that people look at things and make it creative and help the organization grow. They also recognize that since there are so many dimensions that that affect the way people look at their health experience, their community experience, their family experience, their understanding of disability and whatnot, that the organization as a whole acknowledges and owns the need to have knowledge and not allow it to be vested in any given individual. And they change their policies and whatnot to adapt to the community in all ways. So those are some of the thematic pieces that undergird this discussion. And we can stop for a moment to see if anyone has any comments or questions before we go forward. So Tara, you can open it up if you'd like.
Okay, great. So at this time, you can go ahead and raise your hand if you have a question that you want to ask, or you can type in a question, and then we can call on you. I did get one question asking if the PowerPoint will be shared, and yes, it will be shared. It will be posted on our website as well as a video of this presentation. Are there any other questions in the audience at this point? Give people a moment. Let's see. Oh, wait, hold on, I have a question. Let's see. Yvette, did you have a question? I have a yes from you, but I'm not sure. Okay. No, I'm not seeing it. Yeah, so why don't we keep, oh, hold on one second. She says, Yvette says, is the term REL used frequently now?
Is it being used frequently?
Yeah.
No, it's not being used frequently, but it will be. So in some ways, you are on the front end of this abbreviation because, and we'll talk about this, that REL as an acronym is relatively recent. The IOM report just came out a few months ago, and that's where it is anchored.
Okay.
So shall we continue? Shall I move forward, Tara?
Yeah, why don't you move forward?
Okay. Because, let's see, in 2003, the Institute of Medicine produced a groundbreaking report on disparities. And one of the offshoots of that was from the observation that as a field, the health field does not have consistent ways of looking at or measuring or identifying what disparities there are. We do know some things. We have some capacity to understand that there are certain differences in prevalences of illnesses around access to services, around the quality of services, but it's not robust, that there's a mixture of anecdotes, and that within any given system one may be able to do some numerical analysis, but if you wanted to compare the outcomes of the work that's done in San Francisco as compared to the work that's done in Sacramento, there may not be any common way of defining services or data sets, and so as a system, we have been hampered in our ability to understand the nature of disparities in depth and to be able to mark our progress. So there was a committee that was created to really look at this issue and to make some recommendations. And those recommendations came out of the Institute of Medicine this past summer. And so it is this race, ethnicity, language, data project that we will be talking about now. So why collect race, ethnicity, language data? Well, as we mentioned earlier, first of all, it's one way of really being able to assess the quality of care and services for the whole breadth of folks that you are serving in one way or another. So if you were to do any type of statistical roll-up and be able to say that 80% of the folks that you're serving are satisfied with the quality of the services that they're receiving, that's a nice number. If you were able to disaggregate it, though, you might discover that 100% of one group is very happy and would score in the 90s and above, but another group may be scoring the organization in the 50s or 60% are feeling satisfied about the quality of care or services. Or even in the actual measures of quality that a health provider organization may have or a service provider may have, that you're actually seeing that there are differences. So you can't guess at these things. You really need to know. So being able to have that good data helps you measure the quality of the work that you're doing. It also then provides a baseline to discern the differences that is arising from one population in comparison to another population. It provides a foundation that allows you to improve family-centered care, which is so vital for the work that you're doing. That is your core. But unless you have some good data to show that the work that is occurring with the refugees from Vietnam is really comparable in some ways to the quality of work that's taking place with the families that are of Chinese origin and have been in the region for multiple generations. Unless you have that data, you don't know what to improve. And similarly, we talk about being able to develop that targeted intervention. So unless you can actually see what's happening, it's hard to plan differently. And so again, for engagement and outreach strategies, unless you really have the data, it's hard to know what you need to address. And it becomes the baseline for quality improvement efforts that then you can track in terms of progress over time. So those are some of the basic things that speak to the nature of the things that you're going to be doing advocacy on, the type of outreach and engagement activities that you're going to pursue, the way you're going to engage families in dealing with the kinds of issues that they are confronting, and helping to identify what's unique to them because of their cultural experience, and shaping your work with them in reference to that experience. The other thing that's happening is that because as a nation there is more acknowledgement of the importance of addressing diversity in multiple ways, that various legislative pieces and administrative pieces have come into play that are requiring data to be collected. Initially, the main driver was the Civil Rights Act, which was, and so these expectations were driven out of the effort to assure and provide a baseline to assure that historically underrepresented and underserved populations were in fact being served properly, and that the civil rights laws were being addressed in the work. So it was to address some of the compliance issues around civil rights. Over more time, there's also been the effort to collect data for the sake of promoting increased quality over time. So you see this listing of a variety of entities that are collecting data or having an expectation of data being collected. And the direction may be at large hospital systems or public health systems. Some of these are directed to smaller systems in terms of the actual enforcement piece, and other components are for anyone that's receiving funds that may come through federal sources. The states themselves are beginning to recognize that it's in their interest to have certain types of information collected, and so you'll see a listing of some of those states, California being one of them. And so now we get into the question of, okay, we know that it's important to collect the data. We know that that there are quality issues in terms of collecting data, that there are program improvement reasons to collect the data, that there are issues around engagement that are important in terms of collecting the data, and that there are some external mandates that are important to address in terms of collecting the data. So what's the data that we're going to collect? Well, as we saw earlier, race is something that has been codified by people, and the governing group of people that have developed the definitions that we're using today is the Office of Management and Budget. And it is from the work of the Office of Management and Budget that the census creates its data set for the decennial census and the interim studies that it does over between the major decennial census taking. I know most of us are familiar with the census as the definition bearer, but it's actually the Office of Management and Budget. And you see here the listing of the definitions that they are giving to racial groups, American Indian, Asian, Black, or African American, Native Hawaiian, as being part of that list. The rest of the list, white. Some other race is a term that Census Bureau uses that actually wasn't part of the original OMB reference. And another organization that you will need to become very familiar with, the Health Research and Educational Trust, which has worked kind of alongside the Institute of Medicine in some ways, makes a recommendation that when we actually get into the practice of collecting data, that we acknowledge that there are some people who do not see themselves in any of the categories that OMB has identified and will use the some other race. Also in the actual collection data, in the practice, that some people will decline to give that information, or because of the nature of the situation that that information is not available to you. And then there is this definition around ethnicity. Now, as we looked at the definitions earlier, the theoretical definitions of ethnicity, clearly that there are many ethnic groups. We think of early immigrants to this country, the Italians and the Irish and the Germans and the Swedish as ethnic groups. And we look at the difference between what we think of as African American as a racial group or African American as an ethnic group. Those are things that can be kind of interesting discussions. But the Office of Management Budget only identified Hispanic or Latino as a significant ethnic group that it wanted to have tracked within this country. So you have the Hispanic or Latino definition, and then you have the non-Hispanic or Latino identification. And again, when you're actually in the midst of collecting the data, one could decline it or it may not be available. But these are the two sets now that OMB has promulgated as being the racial categorizations and the ethnicity categorizations that were the two types of categories used primarily for civil rights compliance purposes. What this committee did, the Institute of Medicine Committee, what they did was say, well, if we're really interested in quality, if we're really interested in health beliefs, if we're really interested in the myriad experiences that particular cultural groups have as they are attempting to receive services, we really need to get more particular. So they introduced a definition which is called a granular ethnicity, and it captures more of what I was speaking of before. This is a person's ethnic origin or descent, roots or heritage or place of birth of the person or the person's parents or ancestors, and that becomes a very important term, before arrival in the United States. Now, what has happened is that OMB did acknowledge that in some degree and developed an analysis of the ethnic groups that could come within the various racial groups that it identified. So you'll see this list, which has Asian, it has the Hispanic ethnicity, but there are the subgroups underneath that that are also identified as components of the Hispanic group. You'll also see that there are some comments to the side that could be those statements of exceptions, or that members of those groups could be placed in other racial groups as well. So, example, Madagascar, that has more than one racial or ethnic group within its borders, and there could be black Madagascans or Asian Madagascans. So those are some of the uh, little quirks in this category, this system of categorizing persons. So you have the granular ethnicity as one of the elements that the IOM suggested. The other thing that the IOM suggested was that we need to capture issues around language. And they suggested these 4 questions that should be asked to really help us understand the importance of language and be able to plan accordingly. So one would be around how well a person speaks English and how well a person understands English, that English ability question. But the other one that is critical is what language is needed for a health-related encounter. Because we all know that some of the conversational piece is very different from the conversation that one has in a health-related encounter. And in fact, English is not necessarily the same language as medical language, as I'm concerned. We talk about legalese. Well, I think there is a medicalese as well. And we all need to be tutored at times in terms of what the medical languages are. They thought it was important, but not as critical, is to get the language usage, if you could, what language is spoken at home, and also what's the language that's preferred for written material. So these were the contributions from the IOM report. So again, let me pause a bit to see if there are any questions or comments at this point.
Okay, so if you have any questions or comments, you can go ahead and raise your hand and I can unmute you, or you can type in a question. So we'll give you a moment.
None?
Okay, I'm not seeing any come up at the moment. Oh, wait, hold on, I have one hand. Okay, let's see. Norma, let's see if, Norma, can we hear you? You there? I don't think she can speak on her computer. She just sent me in one. She says, will you be covering LGBTI demographic information in this training?
The demographics? No, we won't be talking about the demographics in this. I think what's important to note is that the members of that community are also members of the communities that we're talking about. That they also are members of racial communities, of ethnic communities, and they're also persons who speak a variety of languages. So for the purposes of this material, we're talking about the collection of data that is on the basis of race, ethnicity, and language. And it is important to acknowledge that issues of sexual orientation and gender identity are part of this population as well, as is issues around class, as is issues around immigration status. These are other types of data that become important for us in terms of understanding the whole of what we're about. But today's focus is on those 3 components: race, ethnicity, and language.
Okay. We have a question from Teresa. She says, do you as an organization collaborate and or work with other agencies that address these issues? If so, could you mention a couple?
I'm sorry, the question again?
She says, do you as an organization collaborate and or work with other agencies that address these issues? If so, could you mention a couple, please?
Oh, okay. Well, I think, first of all, the issue around being very precise about collecting data around race, ethnicity, and language is relatively new. Relatively new. This level of precision is relatively new. But some of the work that I do is with state mental health systems as they are working on their efforts to address disparities. And there are New York being one, Massachusetts as another, Maryland as another, are working very hard to align their, Virginia, that's the other one I was trying to get. Virginia is another, and I'm sure that there are others, but these are some of the ones that I'm working with, that they're working very hard to align their organization so that if the Child Welfare Agency is giving counts about the number of African Americans and Somalis and whites and Mandarin-speaking families that they're working with, and the Mental Health Authority is also giving those numbers about the persons that they're working with in the same groups, that they have the shared definition of what those groups are. So that is some of the work that is currently in place in some of the state mental health systems, really working with how do they get the various agencies to have the same definitions, to have the same data sets, so that that they are not talking apples and oranges, but apples and apples with each other.
Okay. And I have one more question from Yvette. She says, if you could only collect one, would you recommend race or ethnicity, or is it imperative to do both?
It's imperative to do both around the accountability issues per se, that the issues around civil rights compliance, that's still present, that we still have to be attentive to maintaining data that support civil rights compliance. If it were a matter of just dealing with issues of quality and the societal issues were things that were not of relevance at a moment in time, then maybe the ethnicity, the granular ethnicity data would be what I would be pursuing. But we're living in a society in which some things are decided by race. And so even if our quality interests were on the basis of the values and beliefs and orientations of the families that we were working with, because they themselves are being labeled by others by race, it's important for us to have that information to understand it and understand the implications for them to be carrying a racial label as well as an ethnic identity. I hope that makes sense. So one is recognizing the context in which we are living as a society and our families are living, and the other has to do with if the world were perfect, what would matter most. Any other questions?
Doesn't look like there are at the moment.
Okay. All right. So what we're moving into is some of the issues when we are actually faced with the task of collecting the information. So what we do know is that families are more likely to provide the information when they understand why it's being requested. That there is at times reluctance to offer information because we live in a society that has not historically used racial identifying information in the way that has been positive. There is that history. It's a real history. However, when they understand why you are asking for it and have felt a sense of trust that indeed you're using it to protect their rights and using it to assure highest level of quality of services for them, then they're more likely to give that information. The other thing is that they're more likely to give the information when they can self-identify, when they're not being told what they are and then being asked yes or no, but being offered the opportunity to declare what their identity is. And back to that sense of safety, when they feel secure that it's not going to be used against them, and that it's not going to be spread around to any and everybody. So that's part of the issue for families, and that in general, once those scenarios are met, that they'll offer the information. Staff are more likely to collect the information, to ask the questions when they understand why it's being requested, when it is felt that the organization actually is going to use the information in a positive way. Easier for most staff if they have a script. And as we go along further, I will introduce you to some examples of scripts that are useful in terms of collecting this information. I would say that, again, because our country is a country in which race, ethnicity, immigration, sexual orientation has been very awkward conversations in our nation, that it becomes also awkward for staff members to begin to put it on the table. But the good thing about this whole initiative is that we are getting to the point that it is easier to put it on the table and not be secretive about it. I recall myself the efforts around identifying family violence, and having routine questions about asking if there had been any violence in the household. Used to be a very, very difficult question for practitioners to use, and you know, and it still is in some situations, but it certainly has become more frequent that the persons are able to talk about those kinds of things that have historically been uncomfortable in social, polite environments are now more comfortable, particularly in the helping relationships. So any questions or comments about that before we go forward?
Are there any questions or comments? You can go ahead and raise your hand if you've got them, or type in a question. While we're waiting, I have actually one. Do you have any ideas for ways to communicate to staff members why the data is being collected? Because I feel like they can often feel like it's superfluous. And have you maybe seen any examples of useful tools to communicate it back to staff?
Well, I think it's in the doing. It's not as much a matter of tools. It is really a matter of the quality of communication and the demonstration that there is not just collection of the data, but that there's analysis of the data and that it is being used. So that in staff meetings or reports that say that there was a community that was collecting not exactly this type of data, but something similar. And what they noticed is that in this case it was African Americans, were coming for services and they would be having 1, 2, 3 visits. And the whites were coming for services and having 6 to 8 visits. Because it was being tracked, they could then say, what's up here? What's going on? And what is it that we can do now to really understand why these visits have been 1 to 6 for the whites and 1 to 3 for the African Americans. It could be something positive. It could be that, oh my goodness, we have really resolved the issues very quickly, and we need to learn what we did for this group that we haven't been able to do for another group. Or it could be, ooh, we're turning folks off, and what can we do now to not turn them off and to help them feel more comfortable with what we're offering. But it's the proof in the doing that I think it becomes the most powerful message to staff members, that they can actually see that they're collecting the information, it's being looked at, not filed somewhere, that it is being assessed, and that they too are part of the process of trying to sort out what it means and what some of the next steps are.
Okay. Does anybody else have any other questions this time? Okay, then why don't you go ahead?
All right. So what the IOM committee was suggesting is that part of the issue is uniformity. And across systems is what, I mean, they're really looking at it big picture and across systems of how we get standardization of the data. And while it may be in hospital systems at one point, it will be in your neighborhood physician's office soon. But the more organizations can begin to routinely collect the same data the same way, the more we as communities, as municipalities, as states, as a country, can really get a handle on what's going on and what we need to do to make things better. So these are some of the guidelines that they were offering, that the information should be provided by the person. If it's an adult, the consumer. If it's a child, the parent, or the person who's taking care of the child. We should not make guesses based on what persons look like or what they sound like on the phone. It should take place as soon as possible. And there's some variation on this, that there are some who feel very comfortable in collecting the information initially, very much right up front with the name, address, and other information. Others feel that it's better to actually establish some rapport and then ask the question, or find another way of doing some follow-up. One organization gave the example of which they would talk about whatever it was that the person needed to talk about, but then at the end of the call, they would confirm the address, confirm telephone number, and at that point also ask the question about race, ethnicity, granular ethnicity. Of course, at the front end, if you haven't clarified the language issues, you may be in trouble. But I think there are ways of finding out when is the best time to raise the questions. And then in terms of the categorizations to use, that you start off with the U.S. Census material in the broad definitions, and then look at the granular categories. And you would use the granular categories that make sense for your own community. So, as you're thinking about which of those lists, as you go back to that listing of the different categories, some communities, there may be 5 or so that they'll want to use. In others, there may be 20 that they'll want to use. So it's based on, who is actually in your community in terms of which of those you would want to set up for. It makes recommendations for electronic format for storing the data so that you can have the easier way of doing the analysis. And as families have concern, to be able to answer those questions as staff members have concerns to be able to answer those questions. So all these are in the service of having a uniform way of doing work. Now, I mentioned earlier the resource for scripts and other tools, and you see the screen here for HERIT. We call it HERIT, Disparities Toolkit, and you'll also see the website for it, www.HRETDISPARITIES.org. I would strongly recommend that everyone on this call go to that site and look at the material that they have available. So they have examples of training strategies, but they also have wonderful, wonderful scripts, and we do have a few that I will show you now, and then you can see more of that when you have more time, as I'm looking at the clock today. So, in any case, let me move to the next one, but this is one of the major resources that we encourage you to use. As you're thinking about your way of listing the various categories, some people find it easier to do some combination of the Hispanic, Latino ethnicity along with the racial identification. So you'll see this list has Hispanic, Latino, white, Hispanic, Latino, black, Hispanic, Latino, declined. So that is an option that some communities or organizations have used. And I'm going to move along a little quickly here. So we talked about the importance of the granular ethnicity, and that as an organization you select the ones that make sense to you. And then I mentioned some of the scripts, and here's an example of ethnicity. Now I would like for you to tell me your race and ethnic background. We use this information to review the treatment families receive and make sure everyone gets the highest quality of service. So first, you consider yourself Hispanic or Latino. And they generally suggest that you ask this question first in terms of Hispanic or Latino identity, and then go to the question around race. And then following that, you would ask a question that speaks to the granular ethnicity. And then you would ask questions about the English proficiency. So I'm going to, I'm looking at the time, Tara, and noting that this material will be made available to you on the website, and you will also get wonderful information when you go to the website of HERIT, the Health Research and Educational Trust, for more details. The one piece that I do want to share with you is that there is at no time should a family member be expected or required to offer information. If they do not want to give their ethnicity or their race, you simply say they decline. There's no reason to argue with it. There's no reason to have debate. There's no reason to say, you know, this is the new rule, I have to do this. But to explain the purpose of gathering the information, and if that doesn't relieve their anxiety, you just say declined. The other thing to remember is that this whole notion of race and ethnicity is something that we may be talking about because it's the work that we are doing. But a lot of people don't go around in the universe thinking of themselves as a particular racial group or a particular ethnic group, and they don't necessarily think of themselves in the same way that the Office of Management Budget does. And in those situations, you just kind of note how they do see themselves. And again, not engage in debate or kind of argue the point. The Harrod has some examples of responses that one could use if a person raises concerns about the information and how to respond. So you'll see these in the PowerPoints, and you'll also see them at the Harrod website. Final note is that Harrod also addresses some of the issues around deaf and hard of hearing population. So I'm sorry for the short ending, but it certainly is the type of thing that people can look at the scripts, play with the various response offerings, try things out for a while, see what works and what doesn't work well in your own setting, and then make the modifications as you need to. So with that, I'll close my comments, and Tara, I'll turn it over to you.
Do you have a minute or two just to answer a few questions, perhaps?
Yes, I do.
Okay. We have a hand raised with Susan. Susan, I'm not sure if you could speak over your computer, but you're open. You there, Susan? Susan, you might have to type in a question then. So I'm going to ask Susan to type in her question. And let's see, Norma. Norma, your line is open. Can we hear you? Okay, Norma typed hers in. She says, do you know of resources related to sensitivity in gathering sexual orientation and gender ID information?
I'm so sorry. That is not information that is at my fingertips, but I can send information to Tara tomorrow, and she can get it to you.
That would be great. Okay. And she says that would be wonderful. Thank you. Okay. Are there any other questions? I'm not seeing any at the moment. But if you have any questions after this presentation, you can, oh, you know, here's one. Okay. Susan says, how do we gather or quantify data for a person of mixed racial heritage?
Oh, that's something that you may want to add as one of the categories that you, in your data screens, that you have the different, that's more like the census data that says more than one race. So the recommendations is that you start with the census data collection format, and the census data format allows for more than one race. So you would include that. OMB does not do that, census does, and I would too. I would just add it. And if people can articulate what those different racial mixtures are, to make an actual notation of that. So yes, add it to your list.
Okay. We have a question from Yvette. She says, do you have any information on disparities for those families LGBT in relation to children with special health care needs?
Again, I'll have to see if there is such information available.
Okay.
Yeah, disparities, LGBT, and disability.
Yeah.
Yeah, I'll have to see if there is information that is captured that way. I have not seen that intersect captured. Again, we know that there's we know that there are issues. We know in the mental health side, we definitely can document some of those issues. In the disability world as a whole, I have not seen it, but I can, again, we'll look.
That would be wonderful. Thank you. Okay, unless there are any other questions, I want to say thank you so much to Vivian Jackson. And as a follow-up to today's call, everyone will receive a survey by email. So please take the time to complete the online survey. If you aren't already on our listserv, you can go to our website, www.familyvoicesofca.org, and sign up. Thank you for joining our call today. If you have any follow-up questions, please don't hesitate to contact me, and keep an eye out for the next trainings. We have a monthly. And also, if you're interested in our annual Health Summit in March in Sacramento, you can visit our website or join our listserv to get more information. Lots of stuff coming up. And thanks again to Vivian and the National Center for Cultural Competence. We really appreciate today's presentation.
My pleasure.
Thank you.